Right. Good afternoon, everybody. Welcome. It is February 19th, a little after 1 p.m. This is House Appropriations Committee, Health and Social Services Subcommittee. I'm Delegate Emily Shetty, Chair, joined by my wonderful Vice Chair, Delegate Dana Jones, and our awesome Committee Council and wonderful Subcommittee members. Today, we will be hearing for three agency budgets. We will go in the following order. Maryland Department of Health, Office of Healthcare Quality, followed by the Maryland Department of Health, Professional Boards and Commissions, and then finally, we will conclude with MDH Administration. We do not have very many witnesses signed up today to testify, only 2 from the public on our last budget. And so I suspect that this could be a slightly earlier day than yesterday. We will begin, as we always do, with our DLS analysis. Welcome, Ms. Martinez. Thank you.
Thank you, Madam Chair and members of the committee. My name is Victoria, and I'll be presenting the Office of Healthcare Quality Analysis. The office licenses and certifies several types of healthcare programs and facilities for compliance with state and federal regulations. As you can see on the first page of the analysis, the fiscal 2027 allowance increases by $1.5 million or 3.6% for a total of $43.8 million. On the next page, there's a discussion of the State Civil Money Penalty Fees Special Fund. There's an increase of $2.7 million in special fund expenditures from this fund to support their contract for nurse surveyors used to resolve a case backlog in the long-term care unit. However, it's unclear why the availability of these funds increases, so DLS has asked the MDH comment on whether the fund has sufficient balance to support this spending. There is one proposed deficiency that adds $1.4 million for personnel to support a shortfall due to lower than expected vacancy savings. Exhibit 1 on page 3 shows a breakdown of the fiscal 2027 allowance. About 87% of the agency spending is for personnel, but there's also about $4 million in the long-term care unit that's mostly supports that nurse surveyor contract I mentioned. Exhibit 2 on page 4 shows personnel spending by monitoring unit, with the largest portions being in the long-term care unit and the developmental disabilities unit. Exhibit 3, beginning on page 5, shows a breakdown of the $1.5 million increase from the fiscal 2026 working appropriation to the fiscal 2027 allowance. The largest increases are for personnel, mainly due to increasing costs of health insurance, and there are smaller changes relating to nurse surveyor positions and other operating or administrative positions. On page 6, beginning on page 6, there's a discussion of personnel data. There's no change in regular positions, but an increase in one contractual position in the fiscal 2027 allowance. The office currently has a vacancy rate of 8% with 22 vacant positions. Exhibit 4 on page 7 shows a breakdown of the vacant positions by program and position type. Of the 22 vacant positions, 12 were for nurse surveyor positions. These are the positions that conduct survey activities. Exhibit 5 on page 8 shows the change in vacant positions by program from 2024 to 2025, showing an increase of 6 vacant positions in 2025. Considering the increase in the vacancy rate, DLS has asked that the office comment on challenges in filling nurse surveyor positions and to discuss recruitment and retention efforts. On page 9, the first key observation discusses the office's mandated survey activities and progress in meeting their goal of surveying all providers annually. There has been significant improvement in fiscal 2025 in meeting their annual survey performance measure. Exhibit 6 shows the annual survey rates in the developmental disabilities unit, which increased from 78% annual surveys completed in fiscal 2024 to 99% completed in fiscal 2025. Exhibit 7 on the next page shows the assisted living unit annual survey rates, which increased from 59% to 81%. And Exhibit 8 on page 11 shows the long-term care unit annual survey rates, which increased from 21% to 65%. The next key observation discusses significant improvements in resolving the annual survey and complaint investigations backlog in the long-term care program. Exhibit 9 on page 12 shows the annual survey backlog with 172 overdue surveys in December of 2023, but as of January 2026, they only have 12 overdue surveys. Exhibit 10 on page 13 shows the complaint investigations completed. There was a significant increase in the number of complaint investigations completed in fiscal 2025, and this progress is mainly due to their contract for nurse surveyors to help resolve this backlog. And DLS has asked the office to provide an update on the timeline for fully resolving the complaint backlog, the plan for long-term use of the subcontractor nurse surveyors, and any staffing needs to continue ensuring timely complaint investigations. The last key observation, beginning on page 14, discusses a change in nursing home survey activities for Montgomery County. The BRFA of last year included a provision that authorizes Montgomery County to request and accordingly requires MDH to delegate authority for the county to conduct nursing home surveys and complaint investigations if MDH failed to comply with certain survey requirements. The office reported that it has sent an MOU to Montgomery County for nursing home surveys and inspections, and so DLS has asked that the Office of Healthcare Quality provide more details of the MOU, including the responsibilities delegated to the county, the start date and length of delegated authority, and the associated cost. And lastly, DLS's recommendation is to concur with the governor's allowance. And that concludes my presentation. I'm happy to take any questions.
Thank you so much, Ms. Martinez. Do any members of the subcommittee have any questions? All right, seeing none, thank you so much. We will invite our colleagues from the MDH Office of Healthcare Quality to join us at the table, please. And Ms. Martinez, you can join us up here. Thank you. And MDH, you can begin when you're ready. Thank you.
Hi, Chair Shetty and members of the committee. My name is Kate Wolf. I'm the Chief of Staff for the Maryland Department of Health, and here today on behalf of Secretary Seshamani, who is unfortunately not able to join us today. We really appreciate all the ongoing work and the DLS analysis here, and I will turn it over to Dr. Sullivan, who is our expert here today.
Great. Thank you so much, and good afternoon again, Chair Shetty and members of the committee. My name is Dr. Meg Sullivan. I serve as the Deputy Secretary for Public Health Services. I will just start off by saying this is my third time appearing before the committee to talk about a very wide portfolio, and I think all of them are so critical and important, but I knew coming into this role, the Office of Healthcare Quality and the work that we do as a top priority is challenging and complex, and continues to be something that we are laser focused on, continuing to move the progress forward that we heard about from our DLS analyst. Just as a brief reminder, the Office of Healthcare Quality is the agency within the Maryland Department of Health that determines compliance with state licensure and or federal certification requirements. Currently, the office licenses over 23,000 providers across 47 industries and have seen a 21% growth rate in the total number of licensed providers over the past 5 years. We have really taken, particularly over the past year, numerous steps to strengthen our facility oversight, including through staffing, through addressing backlogs and inspections, through strengthening our training and quality assurance, and developing operational efficiencies. Hopefully it is clear that we have made tremendous progress, but know that we still have a lot of work to do and look forward to working with you to do that. I will now just briefly review our budget testimony, our written testimony, and then, of course, I'm available to answer questions. We'll, of course, always start off by thanking the governor, the Department of Budget and Management, and the budget committees for their support, and as always, our thoughtful Department of Legislative Services analysts for insightful budget analysis. In the testimony, we were first asked to explain why special fund availability from the state civil money penalty fees fund increases in the fiscal year 27 allowance and discuss how the funding will be spent, including to address whether the fund has sufficient balance to support the $2.7 million for the nurse surveyor contract in the long-term care unit, and whether the purpose of spending is an allowable use of the fund. So this special fund increase in FY27 from this state civil money penalty fees is to address costs associated with long-term care contractual labor. The special fund balance in this fund is currently $2,586,336 as of January 31st. While this revenue source is variable, we do believe there will be enough revenue attainment by the end of FY27 to support expenditures. If revenue attainment falls below the budgeted levels for this contract, then OHCQ will adjust our scope of work accordingly. And importantly, the contract activities are an allowable use of the state civil money penalty reinvestment fund. Next, we were asked to comment on the challenges in filling nurse surveyor positions and discuss our recruitment and retention efforts. I think we'll just start by saying that we recognize that recruiting and retaining qualified nurse surveyors remain one of the key operational challenges affecting survey timeliness, particularly in the long-term care field. And while surveyor positions have been exempted from the statewide hiring freeze and OHCQ is actively recruiting, the market for experienced certified nurse surveyors remains highly competitive due to post-pandemic workforce shortages and salary competition from hospitals, the private sector, and travel nursing. We also know that survey completion has been impacted by the 2025 federal shutdown, although we have made significant progress since then. Despite the challenges that we just talked about with recruiting and retaining, we can say that we have made measurable progress in strengthening staffing capacity. Since July 1st, 2023, we have hired 39 new long-term care surveyors, and 2 additional surveyors are currently in training. Our overall vacancy rate has improved from 22.9% on July 31st, 2022 to a current vacancy rate of 7.3% as of January 31st of this year. And the vacancy rate for nurse surveyor positions is 7% as of January 31st, 2026. We are addressing the challenges that I mentioned through focused recruitment and retention strategies, including accelerated hiring for exempt surveyor roles, structured onboarding and training pathways to build certification and competency, targeted outreach to qualified nurse candidates, and retention efforts that emphasize professional development, certification support, and workload management to sustain capacity and maintain survey performance. Next, we were asked to provide an update on the status of and timeline for resolving the complaint investigation backlog and comment on the plan for use of subcontract nurse surveyors and funding sustainability for the contract in the future, as well as to discuss whether full-time state employee and subcontract nurse surveyor staffing needs to continue to ensure timely complaint investigations. So we had previously projected that the complaint investigation backlog could be resolved within 2 years with the support of subcontractor nurse surveyors. Since implementation in October 2024, OHCQ has used the subcontractor nurse surveyors to increase investigative capacity and improve timeliness for complaint closures while reducing age cases. While significant progress has been made, we do acknowledge the backlog has not yet been fully eliminated, and we continue to rely on the contract to maintain substantial compliance with complaint investigation requirements while completing the remaining backlog. Our current estimate is that the complaint backlog can be fully resolved by October 2026 or within approximately 2 years of the contract operations start, depending on the complaint intake volume and the number of high-priority investigations that require extended timeframes. The FY27 allowance remains necessary to avoid a loss of investigative capacity before the backlog is fully resolved and to sustain timely complaint investigations to prevent a new backlog from forming. Then lastly, we were asked to comment on the details of the MOU with Montgomery County, including the responsibilities delegated to Montgomery County, start date and length of delegated authority, and costs associated with conducting surveys. So we know that Montgomery County has formally requested delegation of authority under the BRFA provision. MDH and Montgomery County are currently negotiating the memorandum of understanding language that would govern the scope and terms of any delegated survey and complaint investigations, and actually have an upcoming meeting in just a few days to continue those conversations. And that concludes the testimony, and we are ready to answer any questions.
Thank you so much. Really appreciate you all being here today. We'll turn to subcommittee colleagues for questions. Delegate Stanko.
Thank you, Madam Chair, and thank you for joining us. You just touched on this towards the end, but the complaint backlog and the contractual use, particularly I wanted to delve into page 18 on the DLS report, and the specifics is there's only a 1.3% increase in contractual services between FY 26 and 27. Do you think that is going to be enough of an allowance to get the backlog fully completed?
So yeah, for the complaint backlog. So this is something that we're obviously looking at closely and is very dynamic, right, as we don't have control over the number and priority of complaints that come in. But I think as we indicated in the testimony and in the analysis, we have made, I think, such significant progress that we do feel like this reflects what we need at this point to be able to continue to make that progress and eliminate the backlog. Of course, it's something that we'll monitor closely and will adjust if needed.
Just as a quick follow-up, once the backlog, let's say you meet that standard framework, can you talk to us about kind of the ongoing expected needs of contractual work versus non-contractual work going forward?
Yeah, I think this is something that we talk about, feels like almost on a daily basis, because I think we are hitting, for the last couple of years, we have really been so much in catch-up mode and are working towards now hitting what our new steady state is, recognizing, again, I think we can really celebrate how much progress has been made, but know that we can't slide backwards in any way. I think we're really trying to determine, again, still taking those final steps to address the backlog, but what does that steady state look like going forward? And we're having ongoing conversations to determine that.
Okay, thank you.
Thank you so much, Delegate. Other questions? Vice Chair Jones.
Sorry about that. Thank you so much, Chair. I had a question on page 7 regarding vacancies. The DLS analysis notes that OHCQ had a vacancy rate of just over 8% with 22 vacant positions as of December 25. We appreciate the efforts that the office is taking to bring down the vacancy rate to 7.3 as of January 31st. But can you describe in detail what recruiting efforts, hiring efforts, or other efforts the office has taken to address the issue of filling vacancy positions, please?
Yeah, so I will say, I think this addressing this vacancy rate with a specific focus on the nurse surveyor positions in particular has been a top priority. We constantly have active recruitments that we are working to do, and in fact, are actively recruiting and interviewing right now. I think, though, also a focus, one of the recognitions that we realize is some of the staffing challenges we've had is about people leaving, right? And so really focused on retention as well. When staff are brought on, making sure that they are trained efficiently but appropriately, feel competent to go and do their roles, and then prioritizing workforce development and engagement throughout the time to make sure that, again, we're not only recruiting but retaining.
Thank you. In the same vein of staffing, I'm sure you're aware of the requirements for Senator Lewis Young's SB 240 and Delegate Warman's HB 965. It's reported at MDH's in the bill's fiscal note. I think OHCQ, can you help me understand or maybe justify one full-time and one part-time health policy analyst to meet the requirements of both those bills? It looks as though DLS estimates that one part-time health policy analyst is sufficient.
I apologize. The bill numbers. Can you just tell me briefly what the bill is?
Yeah.
Sorry, I know we can.
I have my notes, but we have.
I've been trying to learn bill numbers, but I have been looking at them by title.
One moment.
Yeah.
Committee Counsel.
Sorry, it's the bill to establish a stakeholder advisory council. And it was just heard, I think, yesterday or the other day, and it's about in the Senate. It's about to
Yeah. So if I recall correctly, because I know there are, again, a number of bills, but I think it was both the staffing that we look at is both to staff at the work group itself, understanding how much time that goes into that, but also there was some reporting requirements as well. And so to put together those reports and make sure that they meet the needs is what probably went into our staffing analysis. But I can follow up and make sure I get you an exact answer and confirm I have the right
That
bill.
would be great. It's one extra person altogether versus just like a part-time
Yeah.
person. So thank you
Okay.
so much for
Yes, I'm
following up. I
happy to follow
appreciate
up.
that.
Yep.
Thank you, Madam Vice Chair. Delegate McCaskill.
Thank you, Madam Chair. Thank you all for being here. I want to concentrate on our assisted living facilities. Has OHCQ issued any fines or taken any action against unlicensed assisted living facilities in the past 3 years?
Yes. Yep. And we can provide you with kind of a more detailed summary of that information. I will say that, again, talked at the beginning, the complexity and challenges of OHCQ, unlicensed facilities, including those that are providing services consistent with assisted living facilities, is we know, a major challenge and has been a major priority, particularly, over the last, well, I should say, it has been a major priority. I know that our team receives about 8 to 10 complaints a month of suspected unlicensed assisted living facilities. We go out and do investigations for all of them. For those where we determine that there is immediate risk to resident safety, whether medical or suspected abuse, neglect, or financial exploitation, we take immediate action. For those that are not, we issue notices of violation. And then the statute does allow a pathway for them to come into compliance, which we work very closely with them, but they do not come into compliance. We can issue additional notices of violation and/or civil monetary penalties.
Okay, so you gave me about 8 to 10 a month. If you want to
Complaints,
give
yes.
me give up the committee specifics, that'll be great.
Yep.
But how severe were those findings?
So 8 to 10 complaints, and then of those complaints, we go out and investigate. Some of them are not actually providing services consistent, right? It might be most of them are small facilities. It may be a private home. It may be family members. It may be that they're not providing those. In many cases, we find that if they are providing services that are consistent, again, we're not seeing any concerns around immediate concerns around resident well-being, and so this is where we work with them to come into compliance. In those cases where we do see any significant concern, then we take action.
Is that the immediate action?
Correct.
If there's safety
Yeah.
concerns? Okay, Madam Chair, one last bite at the apple. Is there any plan for statewide enforcement to shut down unlicensed assisted living facilities under increasing scrutiny for trafficking seniors?
So I would say, first and foremost, addressing the issue of unlicensed facilities is certainly a holistic effort, and this is where we work very closely, hand in hand, with our Office of the Attorney General, with our Department of Aging, and many other facilities. And we've in fact started up a work group that we have started to meet regularly and have a meeting again next week to talk about a lot of that. I think with the enforcement, right, we look very closely at the statute. Again, when there is immediate threat to safety, we're doing referrals and working with our Office of the Attorney General and/or local law enforcement as appropriate to take those actions. In other cases, when I talked about our other pathways for enforcement through notices of violation, and again, working to come into compliance.
Okay, I may have a follow-up that I may need to just send over to you all. And I said this before, I am the granddaughter of a 100-year-old grandmother. Fortunately, she's able to live in her own home that she's been able to be in, I think, 73 years now. But that's not the case for many of her peers. And so a lot of things and they have lunches together, and sometimes they even try to have sleepovers at 100+ years old. But in some of these facilities that my grandmother often visits, she has a lot of concerns of what she witnessed. And of course, she takes it personal because she wants to just bring her friends home with her. And of course, in the media, we have read and seen many of the complaints that has been, happening in our state. And so I want to just make sure that I put out the ask for this vulnerable population. vulnerable but wise population, that we do everything that we can to protect them, because it just seems like trafficking seniors shouldn't even go together in a sentence. And so I just want to thank you, but I will look forward to the follow-up that you said. Thank
Yeah.
you, Madam Chair.
And we look forward to following up as well. The one thing I do just want to, though, I think to follow up and really stress, one of the messages that we are trying to get out there is public reporting is so essential. So if anybody does see anything that is concerning, we have direct links. You can call, you can fax mail, and do it online. And that is really something that we need. And so really do encourage everyone to report anything they have concerns about. We take it very seriously and will investigate.
Thank you. Good to hear that. Thank you, Madam Chair.
Thank you, Delegate. Delegate Heimbach.
Thank you, Madam Chair. I'd just like to follow up real quick on my colleague's question about unlicensed facilities. Do we have any idea how many people are being cared for in unlicensed facilities?
So I think, unfortunately, right, I think by nature of being unlicensed, it means that they're not reaching out to OHCQ to do the licensure. And so I will just emphasize again that we rely on the public reporting and the complaint process to investigate. So and the overall number is something that is ongoing. When we do get complaints and we go out, again, for many of these complaints, we find that they don't actually meet the criteria of an unlicensed assisted living. For those that we do, the majority are smaller, a small number, but not always. But so I think to answer your question on the broad sense, again, I think it's an ongoing and working with everyone to try and make sure that we're doing broad reporting. And then for this, we can follow up on more specifics around the complaints that we do receive, if that'd be helpful.
I'm just trying to get a better understanding of how the magnitude of the problem. And just a quick follow-up on that, I assume people go to the unlicensed facilities because they're more affordable, they're cheaper than the licensed facilities. Would that be correct?
I mean, I think that definitely is one contributing factor. I think and this is when I talked about the work group and so much of our partnership, particularly with the Department of Aging, is we do need to increase the supply of safe and affordable housing for our seniors in Maryland. I think we know that there's not enough, and that is a priority. I think what we see with some of our unlicensed facilities is one piece of that, yes.
And I'm sure some of them couldn't get licensed, wouldn't pass an inspection, but I'm sure there are probably some of them that are acceptable, they take good care of people. And
correct.
Of course, when you close those, then those people may not have anywhere to go because of the cost, for one thing. So
correct. And I think that's part of, again, when care that is being provided, right, we would consider to be safe and meet the standards to reach a license. That is why we do try and work with them to come into compliance whenever possible. But also a recognition that if they're not meeting those standards, then, right, then we work with them to close and safely relocate residents.
thank you. Before my colleague got me off track, my question was going to be, what kind of initiatives, if any, has the Office of Healthcare Quality taking to help? It's pretty common knowledge at Maryland and our emergency departments have a big backlog and very long wait periods. Have you been able to undertake any initiatives or do anything to help possibly reduce the wait times and the crowds there?
Yeah, I know the issue of emergency department wait times is very broad and complex and kind of straddles many different agencies. I think when we look at the Office of Healthcare Quality and their purview, we do work very closely with hospitals around patient safety initiatives and around some of their discharge practices that has a kind of relates to that. But I think a lot of this falls outside the scope of OHCQ, but is broader efforts across the state.
Okay, thank you. Thank you, Madam Chair.
Thank you so much, Delegate. Seeing no further questions from the subcommittee members, I'm going to ask a couple if I may. Thank you again for joining us today. Really appreciate it. Welcome. I want to first take a moment to commend OHCQ on the tremendous progress you've made on nursing home inspections. That's been a really big challenge that we've seen for the department in general for a couple of years. And just in the last 2 years in particular, I've seen a significant upward trend. This has been a focused effort by the administration to do this, and it's a really good thing that we're hitting these requirements, and as part of that, potentially even catching some violations that could be serious, that could be affecting the lives of some very vulnerable people in the care of these facilities. So thank you for your progress on that. I want to jump in a little bit on the MOU that you're working on with Montgomery County as the sole MoCo rep here. Just want to take a moment to thank the department for working with our county and just ask, can you give I know you mentioned you've got a meeting coming up in a couple days. Can you give a little bit more insight into, how close we are to having this finalized, if there are any barriers that remain, anything that you can share?
Yeah, so I know since I've been in this role, we've had, I think, at least a couple productive meetings. We have drafted an MOU and a statement of work and have sent it over to them. That's what the next meeting is to hear their feedback. So
Can you tell me when that was sent, please? Was it like recently or like months ago?
not maybe a month, but let me verify. It wasn't. Yeah, it wasn't yesterday, but it certainly wasn't months ago either.
Okay.
But we can get you the exact date. And then, so I think it depends on what their feedback is. But I do think that from the meetings that we've had, I think that we seem to be at a pretty good place. I think we're just, working through the final issues is my understanding.
Okay, great. So I know I have previously, thank you. Would you mind please just keeping my office informed of the progress of the MOU? That would be very helpful. I want to ask a question about the training that is provided to your nurse surveyors as they're going out and surveying memory care, developmental disabilities, residences, mental health facilities. What kind of training do they have before they're going to survey these facilities?
Yeah, so I think, that is one, when we onboard nurse surveyors, one of the both challenges but incredibly important things is they're not ready to go in the field right away, right, and have to go through a pretty extensive training process. We have worked very hard to be able to shorten that training time to really focus on the efficiencies, but in no way make or kind of cut out any of those things that we see as most important. So I think it really is, right, understanding what the roles and responsibilities are, understanding the requirements based on, right, which facility they're going out to, both federal and or state requirements. But I think also some of the, kind of considerations that come with being a surveyor as well. I've had the opportunity to go out to OHCQ and meet the staff, and will say that and I know, appreciate you highlighting how much progress we've made in numbers, have heard the staff kind of talk about how it's so personal to them too, right, when they go in and are really looking at every single resident from a resident perspective, not from a checklist perspective. So I think there's a lot of training around that too, because this is a really hard role, and making sure they're equipped to deal with that and really can do their jobs well.
What are the types of things they're looking for, particularly in the facilities where maybe the residents are unable to advocate for themselves?
Yeah, I think a lot of it, and again, it varies. I think I mentioned, right, it's over 47 industries, so it depends on the specific industries. Some of these are very governed. Nursing homes, for example, CMS, the Center for Medicare and Medicaid Services provides very strict or pretty specific things that we look at versus in other facilities. But I know really, looking at building maintenance, looking at any sort of kind of threats to patient safety, looking at care, looking at documentation, making sure patient records. We can get you a very complete list. I think we actually have a couple ready, but it's a wide variety, and it varies based on what they're surveying.
Okay, yeah, I'd be curious specifically on the memory care and DD side, please,
Yeah.
To see what types of things the surveyors are looking for. I know I've shared this with MDH in the past, and I've shared this publicly before, but I'm kind of in the sandwich generation, right, of caregiving for a child who is in elementary school and is amazing, and a mother with dementia who is now in her second memory care facility in Montgomery County. The first one we had to leave very quickly once I discovered that the social worker on staff had, over our family's objections, repeatedly instructed nurses to tranquilize my mom, which I think I couldn't have helped her move out of there faster once I figured out that had happened. What strikes me as particularly challenging is that the OHCQ had just done an inspection of this facility like 2 weeks prior. And the facility had publicly boasted about it on their social media, about how, they had this perfect score or rating or whatever, like they made a graphic about it, which was just insult to injury, knowing that likely when OHCQ visited, my mom's patient file had this in her record. I had to ask them to show me the file when I realized what had been happening, and the justifications that were provided for why they had been tranquilizing her were often none, or that it was time for a shower. She's not a combative person. It was a very scary time for her family to go and see her so disoriented and not understand what was going on. Thankfully, she's in a much better facility now that is in Montgomery County, that is closer to our family, and we are able to visit very frequently and see her care is far superior there. But I just, I don't know what my ask is other than to say, I hope that as we are hitting these great numbers and we're maximizing the need to get surveyors out to inspect these facilities properly, that we're not sacrificing anything, that we're actually doing a very thorough job, so that especially the residents in these facilities are getting the care that they need. Yeah. So that is the end of my questions that I can get through today. I'll follow up if needed. Seeing no further questions from subcommittee members, thank you. Thank you for your time.
Thank you.
We will now go to our second budget today, our MDH Health Professional Boards and Commissions. Welcome back, Ms. Martinez, to the table, our Department of Legislative Services analyst, who will share her analysis. Thank you.
Thank you, Madam Chair and members of the committee. My name is Victoria, and I'll also be presenting the Health Professional Boards and Commissions analysis today. The Health Professional Boards and Commissions include various boards that work to certify and license health professionals and to resolve customer complaints. As you can see on the first page of the analysis, the fiscal 2027 allowance increases by $4.4 million, or 9.5%, for a total of $51 million. The majority of the budget is funded through special funds that's generated through licensing fees. Fiscal 2025, that's discussed on the next page, included a total of $6.2 million in canceled funds. Most of this is just reimbursable funds in the Board of Nursing for infrastructure operations to align with the general fund appropriation that's budgeted in the MDH Office of the Secretary. Exhibit 1 on page 3 shows a breakdown of the agency spending for fiscal 2027, most of which supports personnel and various contract expenditures. And Exhibit 2 on the next page provides a breakdown of the allowance by board, with most of the spending supporting the Board of Physicians and the Board of Nursing. These are the largest boards. Exhibit 3 on page 5 shows a breakdown of the $4.4 million increase from the fiscal 2026 working appropriation to the fiscal 2027 allowance. The majority of the increases for personnel expenses. There are also other changes in the Board of Physicians and Board of Nursing, in addition to various software-related changes and other shared operating costs. Turning to page 7, the Budget Reconciliation and Financing Act includes 2 board fund balance transfers. The first is a $2 million transfer from the Board of Physicians to the MDH Office of Population Improvement to support the Maryland Loan Assistance Repayment Program for physicians. And the second transfer is a $500,000 transfer from the Board of Professional Counselors and Therapists to support the Behavioral Health Administration's Community Services Program. Exhibit 4 on page 8 shows the estimated special fund balance of the 2 boards and the balance as a percentage of their allowance. It's recommended that the fund balance remains at 20% of the allowance, so the boards are still left with sufficient funding after the transfers. Exhibit 5 on page 9 shows transfers from the boards authorized in past BRFAs, including in fiscal 2022, 2025, and 2026. Overall, most transfers in recent years were also from the Board of Professional Counselors and Therapists. In terms of personnel that's discussed on page 10, beginning on page 10, there's a slight increase in regular and contractual personnel. The boards had a vacancy rate of almost 9%, which are mainly administrative positions. However, the boards have made significant improvements in filling vacant positions in recent years. And Exhibit 6 on page 11 shows the change in vacant positions by board from 2024 to 2025, showing overall improvement in filling those vacant positions. The first key observation, beginning on page 12, discusses the board's licensing activities and complaint investigations in fiscal 2025. Exhibit 7 on this page provides an overview of the new and renewal licenses issued by board in fiscal 2025. There is a new licensing requirement for assisted living managers that's discussed beginning at the bottom of this page and onto the next page. This will begin in fiscal 2027, and because of this new requirement, the number of licenses issued by the board is estimated to increase significantly. Exhibit 8 on page 13 shows the increase in the estimated licenses issued by the State Board of Long-Term Care Administrators compared to their budget in fiscal 2026 and 2027. As shown, the number of licenses issued increases significantly, but the budget reflects only a modest increase. So DLS has asked that the board comment on whether the fiscal 2027 budget provides adequate resources to address the increase in licenses issued. Exhibit 9 on page 14 shows the complaints investigated and the complaint rate by board. This data is based on the Managing for Results submission, and although the Board of Nursing had the highest number of complaints investigated, the MFR data doesn't include the complaint rate for the Board of Nursing. So considering this, DLS recommends adopting committee narrative, requesting that the complaint rate for the board be incorporated in their annual MFR submission. The second key observation, beginning on page 15, is on the status in meeting MFR goals. The boards have several goals relating to the timely completion of issuing new and renewal licenses and investigating complaints. Exhibit 10 on page 16 shows the boards' performance in meeting their MFR goals, with most boards meeting these goals with 100% timely completion. Exhibit 11 shows the number of boards that missed each of these goals in recent years, showing that there has generally been improvement in the number of boards meeting their goals. And then Exhibit 12 on page 18 shows performance specifically for the timely complaint investigation goal with the bold text indicating that the board missed the goal that year. Although 4 boards missed this goal in fiscal 2025, this is an improvement from prior years. And the last key observation, beginning on page 19, discusses an evaluation of the Board of Professional Counselors and Therapists that was completed by DLS's Office of Program Evaluation and Government Accountability. The evaluation reported several findings related to management and staff, budget, enforcement of pre-licensed professionals, and operational independence. One of the findings that OPEGA highlights is insufficient tracking of licensing applications. Although the MFR data for the board indicates that 86% of initial applications were processed within 10 days of receipt of the last qualifying document, OPEGA found that the average time to approve initial applications was 96 days. And the bulleted list on page 20 shows the steps in the licensing application process. So although the application process begins at step 1 with the applicant's initial application, the MFR measure tracks the number of days from payment of the fee for the license, which is in step 5. So the MFR doesn't reflect the entire processing time for the applicant, as it tracks timely completion once the review process has already been finalized. And so DLS has asked MDH to discuss whether other boards also measure the MFR in the same way to better understand how to improve the MFR measure. And DLS has asked the board to provide an update on implementing these recommendations, and also recommends adopting a committee narrative requesting a report with an update on implementing the recommendations. And that concludes my presentation. I'm happy to take any questions.
Thank you, Ms. Martinez. Does anyone have questions for our wonderful analyst? Not at this time. Thank you. Please join us up here, and we will bring our friends back from MDH again. Please, MDH team who's testifying, I have quite a few names here listed, but my last list was wrong, so I'm not going to guess who's coming down. Welcome, and when you join us down here, please take a moment to introduce yourselves for the record before you begin. Thank you, and you can begin when ready.
Good afternoon, Chair Shetty, Vice Chair Jones, and members of the Health and Social Services Subcommittee. For the record, I am Clint Hackett, the Deputy Secretary with responsibility for operations at the Maryland Department of Health. Today I am joined by Rhonda Scott, Executive Director of the Board of Nursing, and Lorraine Smith, Executive Director of the Board of Examiners of Psychologists. The department thanks the Governor, the Department of Budget and Management, and the Department of General Services and the budget committees, including this subcommittee, for their support. We also thank the Department of Legislative Services, including Budget Analyst Victoria Martinez, for the insightful and thorough budget analysis, as well as for the recommendation to concur with the Governor's allowance. As a reminder, it should be noted that the boards, with the exception of the Board of Nursing, operate independently. However, together we collaborate to serve the mission, and the department does provide operational support for the boards in the spaces primarily in human resources, procurement, and fiscal support. In the DLS analysis, the MDH health professional boards and commissions were asked to respond to 4 items. Today we plan to review responses to these items with this subcommittee for the record. So firstly, we were asked to, the State Board of Long-Term Care Administrators was asked to provide any updated estimates of the number of licenses for assisted living managers in fiscal 2027, a description of the board's implementation plan for addressing the increase in licenses, the positions needed to address the increase in licensing activities, and a discussion of whether the fiscal 2027 allowance provides adequate resources to implement the expansion of licensing activities. The estimated number of licenses to be issued by the State Board of Long-Term Care Administrators to assisted living managers in fiscal 2027 is 1,628. This estimate is based on data from the Office of Healthcare Quality's Directory of Assisted Living Programs currently licensed in Maryland. As a result of House Bill 874, State Board of Long-Term Care Administrators requirements for assisted living managers, the licensing requirement was extended from October 1st, 2024 to July 1st, 2026. As required by Chapters 785 and 786 of the Maryland Acts of 2024, the board is required to submit reports to the House Health and Government Operations Committee and the Senate Finance Committee regarding its preparedness to license and regulate ALMs. Reports are due on or before October 1st, 2024, 2025, and 2026. The required reports must address the board's readiness to implement assisted living managers licensure by July 1, 2026 in the following 6 areas: the dates by which the boards intend to begin receiving applications and issuing licenses to ALMs, the status of appointing ALM members to the board, staffing levels, including the number of personnel employed and the status of filling vacant positions necessary to implement ALM licensure requirements, the capability of the board's software platform to accept applications, issue licenses, including timelines for any necessary information technology enhancements, the time frame and steps taken and to be taken to inform assisted living programs and assisted living managers of the new licensure requirements, and any additional policies the board anticipates adopting to implement assisted living manager licensure requirements. The board submitted reports on October 1st, 2024 and October 1st, 2025, providing updates across the 6 required areas. The most recent updates relevant to the anticipated increase in licensure volume are summarized. With respect to the application processing platform, the board will utilize its existing online licensure platform to process assisted living manager applications. The initial application portal for ALMs is anticipated to go live on April 15th, 2026. The platform has been used successfully for nursing home administrator licensure since September 16th of 2024. The system incorporates a smart sheet-based document upload function supporting the board's transition, completed in February 2025, to a fully electronic paperless process for receiving, storing, and managing application materials. Application requirements and processing efficiency. Under newly adopted regulations, the estimated 1,628 individuals who have practiced as assisted living managers in a licensed assisted living program in the state prior to July 1st, 2026, will be permitted to attest within the online application to meeting all licensure requirements, qualifications, trainings, and certification standards, except for one specified requirement. This attestation process is expected to significantly expedite staff review and license issuance. With respect to notifications and timeframes to promote transparency and to ensure timely awareness of licensing requirements, the board sent notifications to assisted living managers on October 28, 2025 and February 2nd, 2026, providing updates on the status of assisted living licensing requirements. The most recent communication advised that licensing requirements will be posted on the board's website on February 13th, 2026. And then with respect to staffing levels and resources, the board's fiscal 2027 budget includes 5 regular staff positions, which aligns with the operational demands associated with increased licensing activity resulting from the new ALM licensure requirement effective July 1st, 2026. In 2023, the previous executive director submitted an over-the-target request for 3 mission-critical positions in response to legislation that became effective October 1st, 2022, which originally established an ALM licensure implementation date of October 1st, 2024. These positions were approved in fiscal year 2025, and the associated appropriations are incorporated into the fiscal year 2026 and 2027 budgets. We were next asked to respond to an item specific to the Board of Nursing. And basically, the ask was considering that the Board of Nursing received and conducted the highest number of complaint investigations, but the MFR data did not report the complaint rate. The Department of Legislative Services recommends adopting the committee narrative to request that the department include the total licenses and complaint rate for Board of Nursing in the annual MFR submission. And the board does concur with this DLS recommendation to include nursing in all total licenses and complaint rate data reported to DLS through the annual MFR or Managing for Results submission. MDH was next asked to discuss whether the other boards should consider the receipt of the licensure fee as the last qualifying document when it comes to measuring timeliness of application processing from receipt of the last qualifying document as reported in the annual Managing for Results submission. Now, the Board of Physicians has online applications for most practitioner types. Applicants pay an application fee, and once the application has been approved, the applicant logs in, pays a licensure fee, currently by credit card only, and can then download their license. As an example, from January 1st, 2025 to February 16th, 2026, the board received 1,832 applications for physician initial licensure. The average time from first payment, that's the initial application fee, to approval for licensure was 10 days. And then the average time from the first payment to license was 13 days. So there was a 3-day sort of window in between the approval of the license and the actual applicant downloading that license. For the remaining paper applications and all reinstatement applications, the fee is paid at the start of the process, so the last document received is not payment. The licensure and certification fee for the Maryland Board of Nursing is one prerequisite for the issuance of any licensure or certification. So for the Board of Nursing, once the fee is paid and the application is submitted, staff must review the application to verify that all minimum requirements, including additional required documents, are satisfied. For the rest of the health occupation boards, there are either a separate application and license fees or a combined fee. For boards that require both an application fee and a license fee, the licensure fee is the last qualifying document before issuing a license. For boards that have a combined application licensure fee, the fee is not the last qualifying document before a license is issued. And so boards that have an application fee only, where the application fee is not the last document before license, include the Board of Acupuncture, audiologists, morticians, optometry, pharmacy, physical therapy, psychologists, and residential childcare. And the boards that do have, as in the example we reviewed, an application and licensure fee include the Kidney Disease Commission, the Dietetic Practice Board, Podiatric, Long-Term Care, chiropractic, massage therapy, dental, social work, and environmental health. The department and the Board of Professional Counselors and Therapists was asked to provide an update to the committee on activities and a timeline for implementing OPEGA's recommendations to continue monitoring progress in improving the board's operations, DLS recommends adopting the committee narrative to request that MDH, in collaboration with the Board of Professional Counselors and Therapists, submit a report with an update on activities to implement the recommendations in the OPEGA evaluation. And so the Board of Professional Counselors and Therapists did indicate their appreciation to respond to the findings and recommendations of the OPEGA evaluation, specific to staffing structure and merit positions. Since the issuance of the report, the board has taken proactive steps to strengthen its workforce capacity and to reduce operational strain in a number of areas. So they would identify active recruitment efforts. The board has worked in coordination with our department's Office of Human Resources to initiate recruitment for vacant positions and to prioritize critical roles necessary to maintain licensing, complaint processing, and compliance functions. The board is still actively recruiting since some staff took advantage of the state early retirement program and other staff resignations. Then there's the assessment of contractual positions. The board has conducted an internal review of contractual PINs to determine feasibility for conversion to merit status. This review was guided by workload sustainability, turnover patterns, and long-term operational needs. Then there's the advocacy for merit conversions. Consistent with OPEGA's recommendations, the board has formally supported the conversion of select contractual positions to merit positions to provide workforce stability and to improve retention and to reduce disruption in essential regulatory functions. With the assistance of the Department of Health's Human Resources Department, the board was able to convert contractual employees into merit PINs for 2 contractual employees. Then there's the exploration of human resources shared support. The board has engaged in discussions regarding shared human resource liaison services to streamline recruitment timelines, reduce hiring delays, and to improve onboarding efficiency. Working with the HR liaison since the evaluation has been a much smoother process. And then there's workload monitoring. The board continues to evaluate staffing levels against increased licensing volume and investigative caseload to ensure alignment with statutory obligations. The board remains committed to collaborating with the Department of Health to implement structural improvements that promote operational stability and accountability. Converting contractual positions to merit positions where appropriate remains a key component of strengthening the board's long-term capacity. Before I close and open for questions, I will just indicate that, we have a renewed interest in collaborating with our board and commission partners. This year, I am personally making it a point to go out and to visit with each of the boards. I've visited with 2. I plan to visit with 3 more in the month of March. And the goal really is to collaborate with the boards to ensure that, the mission of protecting the public by ensuring we have, properly credentialed providers and to ensure that we're able to receive, investigate, and resolve complaints in a timely manner. So my portfolio, again, involves the operational pieces of things. So I'm really looking to collaborate with our board partners to see how we can expedite human resources. How can we staff more quickly? Sometimes, there are bottlenecks in fiscal spaces, procurement spaces, and we are just being really mindful of that and continuing to commit to partner to move things forward and to ultimately improve the performance operations of these boards. So the department does commit to that. They may not be outside of the Board of Nursing, part of our day-to-day operations, but I can tell you in my meetings with the executive directors, there's a genuine interest in collaboration, partnership, and moving things positively forward for our constituents and the people that we serve. In closing, I will say that, we are happy to take any questions that you may have at this time. I do have the subject matter experts from the Board of Nursing and the Board of Examiners of Psychologists here with me. We'll do our best to answer questions that come our way, but I do want to let you know that we don't have participants from two of the boards that showed up in this report today, which was the Long-Term Care Administration and the Board of Professional Counselors and Therapists. So we encourage you to ask questions specific to those boards, but we will have to take those back and follow up with responses expeditiously for you. So with that being said, I open the floor and happy to entertain any questions that you may have for us today.
Thank you, sir. Appreciate your testimony. Delegate Heinbaugh for questions.
Thank you, Madam Chair. Well, thanks for your, I thought, pretty thorough response to the DLS report. You spent a lot of time talking about the increased licensed requirement. Could you just real briefly describe what that process is? I mean, I've read that you take a course. Is there a background check? Do you have a test? Or just real quick, describe what that process is, how long it takes.
I'm gonna start that off, and I'm gonna hand off, and I'm gonna start off by saying it does vary depending on the board, right? So I'm gonna ask Rhonda to speak specifically to the Board of Nursing, and then I'm gonna ask, for you to speak specifically, because you cover most of the smaller boards. So maybe you can kind of give a general consensus for what happens in that space. But we can start with Rhonda, if you're okay.
Sure. Thank you for that question. So as far as the licensing process goes, we license approximately 230,000 active licensees and certificate holders at the Board of Nursing. And so there are various health professionals that we license and certify, registered nurses, licensed practical nurses, certified nursing assistants, dialysis technicians, direct entry midwives, electrologists. And so all of those processes are going to be different because of the different licensure and certification requirements. But the first step is to submit an application before the board, pay the fee, and then as far as the board staff will then look at the minimum requirements for licensure or certification and if they are met, whether that's the education and training, practice requirements for renewals, certain certifications for direct entry midwives and electrologists. And so it's once all of those requirements have been met as the licensing specialist reviews them, that's when the license or certification is issued. So it just varies amongst the multiple licensure types that we regulate.
Would you add anything, Lorraine? The same for you.
I thought he was going to ask a follow-up question.
No.
Well, I'm just curious. I want to make sure I understand. I think you said you have the resources to be able to achieve the goal of processing all those licenses by the 1st of July?
He's referring to long-term care.
Oh, okay.
Yeah, that is what they provided in their response, but I can definitely follow up on that to confirm.
Okay.
Yeah.
And then the last thing real quick, there's a renewal process, I assume at some point they have to be renewed. And so it'll be a continuing requirement as you go forward.
Rhonda? For renewals, is it the same process?
Yes, so the renewals process is going to be a little more streamlined because it's less requirements needed.
Okay, thank you very much. Thank you, Madam Chair.
Thank you, Delegate Heinbaugh. Go ahead, Delegate Ruff.
Good afternoon. Thank you, Madam Chair. And thank you to the panel. My question is around the outstanding 26 cases with questionable documentation that the Maryland Nursing Board carefully are investigating, and about those applications where they received license with fraudulent documentation. Wanted to know if we can get an update on that, because we obviously want to make sure that Marylanders are getting the highest quality of care that they deserve, and obviously ensuring proper licensure and that we're fretting out any fraudulent applications is a high priority. So we appreciate those efforts that are being taken to look into this, and wanted to know if you could just give us an update on where you are with that.
Absolutely. So, so the 26 investigations were, the goal that we had to complete them was by July 31st of 2025. What we did was, those cases, of course, were reviewed, investigated, and they were, 5 of those cases were closed by take no action. 10 individuals withdrew their RN application to Maryland. 2 individuals surrendered their privilege to practice. 5 cases were submitted to the board committee, the report of investigation committee, after the investigation was completed for charging. 4 cases are still being actively investigated. And then on January 9th of this year, the update is 2 of the cases were closed by take no action, and the other 2 investigation reports were submitted in November and December of 2025. So those cases are waiting to the board to make a decision on charging. So we've pretty much closed the loop on all 26 now. They're just, those last 2 have been submitted after the investigation was conducted.
Very good. May I just have a follow? You know, we I think as a subcommittee have concerns about the issues that were raised by the Joint Audit and Evaluation Committee back in October. And so I wanted to know if you could speak to the efforts that the boards have been taking to centralize oversight efforts since those findings came out about the policies on criminal background checks for health professionals.
Yeah, I will take that. Thank you for that question. That ties directly into the reference that I made earlier about me personally going out. And
I'm so sorry, sir. Your mic is not lit properly. Can someone please handle that? Sorry. I apologize.
It's not your fault.
It's not your fault.
Let me-
Thank you. I just want to make sure we could hear your great answer. All right,
Okay.
thank you.
Am I good now? You're good. All right, wonderful, thank you. Yeah, that is a good question, and it ties back to the update I provided earlier. You know, coming out of that hearing we had, the commitment to sort of not only collaborate more closely with the boards, it actually gets into audit findings and being able to be more responsive and to ensure progress is being made on findings that are, you know, reported for the board. So what I am doing is I'm going out and I am sort of having conversations with each of the executive directors to collaboratively come up with an approach for how we can most effectively do that. We don't, as I mentioned in a prior hearing, we don't really have the direct, you know, statute basically controlling or mandating, you know, oversight. But what I'm detecting and experiencing is a great partnership on behalf of the boards to work with the department to move the needle in that space. So as I go out to each of the boards, this is something that I have on my agenda for, you know, socializing ideas between us two for how we can improve that. And I would say once I finish my roadshow, I should have sort of or we as a department should have a more formal recommendation for how we can move forward with that oversight. We really take the approach of collaboration with the boards, and I think, you know, going with that, taking that pathway will let's say, increase the likelihood of us being able to undertake that exercise effectively.
I hear you. I just don't know if that fully answers my question. I mean, are you going to be implementing a, you know, uniform background check policy?
Right.
And how are you going to implement that? How are you going to, you know, prevail upon the boards to ensure that there is consistency? You know, because our colleagues, Delegate Solomon and Senator Hendelman, you know, voiced some serious concerns as they went through these audit processes.
Yeah.
And, you know, I think we all can understand how important it is to understand who we're dealing with, especially in the context of healthcare being provided. So could you tell us just a bit about what the specific plans are?
I'm going to hand over to Lauren, but one thing before I do, I get where you're coming from now, and I do remember that particular audit finding as you went things over. My recollection I would say two things. There is a willingness of the boards to implement those background checks, but my recollection of how the responses came back was that the boards basically, in some cases, they have to, actually get statute put in place to sort of meet those requirements. So I think, going back to my initial response, I think as I go with, talk to these boards, we know that the desire and interest is there. I think what I will be trying to ascertain is what obstacles lie in the path from, getting that statute, getting those bills in place for those boards that require that to be able to get that implemented. But my recollection was a lot of the boards felt it was a good idea, but they did need the legislation in place to be able to move that forward. Lorraine, I don't know if you want to add to that.
Sure, I can answer to that. Hi, I'm Lorraine Smith, and I'm with the Board of Psychologists. And I'm actually here because I'm the fiscal liaison for the smaller boards. So that's my role here, actually. But I can speak some on the background checks. This legislative session, we actually have a joint bill in for all boards to those that don't have background checks will have background checks. And we will also be, in that bill is also the RAP back. I don't know if you're familiar with the RAP back system. And that's where CJIS will automatically notify boards when a licensee, if there's a hit on them, meaning if they're arrested in some other state, that they will contact the boards and let us know. So we will be alerted to any kind of incident as it relates to criminal. And so that board is actually, that bill should come up this session. It's already been submitted, and unfortunately, I don't have the number. I don't have the board number, but it's a joint bill.
We can follow up with the number on the sponsors.
Yeah, we can follow up, because initially it was going to be, the state was going to actually get the sponsor, but I don't think that happened. It actually, someone else got the sponsor. But I can look that up and get back with you on that.
Yeah, it would be interesting to know who the sponsor is so that we can kind of liaise with that person and be, have more understanding of the nuances of the bill. Because like we mentioned, the idea that the Board of Pharmacists doesn't do background checks, I agree with Senator Hedelman that that's a huge oversight, especially dealing with that subject matter. Really need to make sure we have that uniformity. Thank you very much. Thank you, Madam Chair.
Sure.
Thank you. Delegate McCaskill.
Thank you, Madam Chair. I just want to refer to page 21 specifically, and it's in reference to the timeliness of complaints, investigations, not properly documented. And so I was reading in the DLS report that on page 21 that OLA audit found HPBC did not investigate complaints in the required time frame, and that more than 3,000, I think 3,051 to be specific, complaints in the complaints were open for more than 2 years. My question is, for the record is, can you comment on the specific actions that MDH and BPOCT has taken to remedy the issues of addressing complaints in timely manners?
Yes, that is one that I will have to take back because the board is not here today. But I get the question, can we comment on the specific actions that are being taken to ensure that these complaints for the board is being resolved in a timely manner?
And for the record, same thing, as you reference back to the video, when you go back to your go back to your agency, when can you provide that report and update? How long do you think that might take to get that information?
Sure.
To implement the recommendations provided by OPEGA evaluation?
We will try to get that back to you in 2 business days. That should not be difficult. My suspicion is that some of that does exist in the response that they give to the audit finding.
Okay.
So we should be able to pull that and then get the board to confirm their actions.
It'd be interesting to see what those recommendations are. Thank you, Madam Chair. Thank you, sir.
Thank you, Delegate. I'm going to ask a couple of questions that I know Madam Vice Chair wanted to ask, but she had to run to a bill hearing for one of her bills. So on page 20 of the DLS analysis, OPEGA found insufficient processes in tracking licensing applications that were leading to an average wait time for approval of initial applications of 96 days. Have you all been creating a unified system to track these initial applications? And can you elaborate, please, on any efforts that the department has taken to streamline the measurement for performance in licensing applications?
That is also a follow-up that I would have to come back for you. So your question specifically is, and I'll answer a component of it in terms of tech, but the question that you're asking is, what are the processes the department is implementing in coordination with the board to streamline the tracking of the MFR metrics? Is
Yes.
that correct? Okay.
Yes. Thank you. Appreciate the follow-up. And then the last question that Vice Chair Jones had that she wanted me to make sure to ask is that we really appreciate the efforts that you all have taken to address vacancies in the past year. On page 10 of the DLS analysis, DLS notes that as of December 31st, the vacancy rate was 8.9%. Can you please elaborate on any specific efforts taken for outreach, recruitment, hiring, and reducing the vacant positions?
And this is specific, again, to the Board of Professional, yeah. So we will take that back. So this is specific efforts that we are undertaking to improve the recruitment efforts. Okay,
Thank you.
absolutely.
Further questions from the subcommittee? I will ask one really quick, sorry, one last one. So on the object fund difference report, page 28 of the DLS analysis, there's a 463, rounding up, % increase in the allowance for FY27 for equipment replacement. Can you talk a little bit more about that?
I'm sorry, that is page 27, you said?
28, please.
Oh, I see, the equipment replacement, the 462.6%.
Yeah.
We
you
will
want-
take that as well and follow up.
Thank you, appreciate it. Okay, any other questions from subcommittee members? All right, thank you, appreciate
Thank you for your time.
Thank you. All right, that concludes the hearing for the MDH Health Professionals Boards and Commissions. We will now turn to our third and final hearing of today, Maryland Department of Health Administration. We will welcome Ms. Naomi Kimura, our DLS analyst, to share her thoughts on the budget, and then we will turn to MDH, followed by our witnesses. Thank you, Ms. Kimura, in advance. You can begin when you are seated.
Good afternoon. My name is Naomi Camaro. I'm the budget analyst with DLS, and I will be presenting the fiscal 27 budget on the Department of Health Administration. This budget includes funding for the major IT projects across the department, the operational functions of the department, and funding for the 11 state hospitals across the state. So starting on page 1, you can see that the budget in fiscal 2027 is decreasing slightly by about 0.8% to a total of $841.2 million. On page 3, we begin discussion of a couple different performance measures that MDH submits data on. These are both related to the state hospital facilities. The first one's related to safety. The chart on page 4 shows the rate of patient on staff assaults per 1,000 patient days at each of the 5 adult psychiatric facilities and the 2 youth psychiatric facilities. The department has a goal of fewer than 1 assault per 1,000 patient days, and this chart is showing that only 1 of these facilities met that goal in fiscal 2025. The Finance Center got close. But there have been some reductions, including at the Rica Baltimore facility, although the assault rate remains high. The second measure is related to court-ordered patients. The department is required to place individuals who are found incompetent to stand trial or not criminally responsible in appropriate facilities, in most cases within 10 days. However, this has been quite challenging for the department due to an increase in court orders. They indicated that they have received 67% more court orders in fiscal 2025 compared to fiscal 2021. They're also operating their 5 adult psychiatric facilities at near capacity, despite admitting only forensic patients at this time. The chart on page 5 shows the number of patients that are admitted within 10 days and not within 10 days between fiscal 21 and 2025. And so you can see in 2022, 23, and 25, the department was unable to place any patients within the required 10-day time frame. And then in fiscal 2025, I also wanted to point out that the average amount of time it took to place a patient was 56 days. So the rest of this discussion talks about why this is such a challenge. So as I just mentioned earlier, each of the 5 adult psychiatric facilities are operating at near capacity. Page 7 has an exhibit that shows the fill rates at each of those facilities. And so you can see each one is operating at least at 94%. On page 8 includes discussion of some of the proposed efficiencies included in the fiscal 27 budget, which add a net increase of $10 million to the fiscal 26 budget. And I wanted to point out the last bullet on that page is $14.3 million, which supports department-wide overtime expenditures in fiscal 2026. We've also noted that MDH had the second highest level of overtime expenditures and hours in fiscal 2025 compared to other state agencies. And so we've asked MDH to provide an explanation for the high levels of overtime in each of those years and discuss any efforts that it's taking to reduce overtime. On page 9, we have a pie chart summarizing how the expenditures in the MDH administration fiscal 27 budget are split up. So a majority of funding is allocated to support the personnel at state hospital facilities. The state hospitals employ nearly 4,000 staff, and so that's a big portion of the budget. On page 10, there's another pie chart. This looks at administrative and operational spending, not including the state hospital spending, just to provide more detail. This includes 17% of this tranche of funding is for opioid response, so that includes special funds from the Opioid Restitution Fund, but it also includes general funds that are distributed through the Maryland Office of Overdose Response or more. Page 11 and 12 has the proposed budget change chart that highlights some of the major changes in the budget in fiscal 27. So as I said earlier, the budget's decreasing slightly by about $6.9 million. The increase is driven mainly by increases in employee and retiree health insurance. There's also $14.9 million in fiscal 27 to support contributions for the Family Act that are prorated and will begin in January 1st, 2027. And then these increases are offset by a few different areas of decrease, including delayed major IT projects throughout the department. And then there's also a decrease in anticipated expenditures for the Opioid Restitution Fund in fiscal 2027. The next section is about the Opioid Restitution Fund. So we've summarized how these dollars are being spent. And I first want to just talk about how they're supposed to be spent. So the majority of the settlement awards are required to be distributed per the settlement agreements. And so these bullets list out how that works. So 25% of the awards go directly to the locals, doesn't go into the Opioid Restitution Fund. And then 45% of the awards are distributed as block grants through the Targeted Abatement Grant Program. 15% are for state discretionary grants, so those are distributed through a competitive process to local governments and nonprofit organizations. And then the last 15% is for the state allocation. And so that supports various projects and initiatives that are allowable under the settlement terms. So for example, in fiscal 26, there was ORF funding that supported medication for the treatment of opioid use disorder at certain correctional facilities in the state. The exhibit on page 13 shows how this funding is distributed between those different categories in fiscal 25, 26, and 27. And MDH indicates that as of the close of fiscal 2025, the balance of the ORF totaled $116.9 million and projected revenue for fiscal 26 to be $24.5 million. The fiscal 26 working appropriation includes $67.6 million in expenditures from the fund, and the fiscal 27 allowance includes $28 million in expenditures from the fund. In the chart, Exhibit 7, there's quite a bit of funding that is labeled as unallocated. This is funding that is in the budget, but we hadn't received how that funding would actually be spent in fiscal 26 and 27. Since this writing, MDH has been able to provide a little bit more detail, so I'll let them talk about that in their testimony. We asked MDH to clarify how the unallocated dollars will be spent in fiscal 26 and 27, and their plans to spend down the fund balance. Next, I'll talk about personnel. On page 14 and 15, we describe some of the personnel changes. There is a decrease of 12.2 positions in MDH administration in fiscal 27. That's driven by the abolition of 15 positions at Perkins. We've asked MDH to provide a reason for these position eliminations given the facilities challenge with staffing vacancies. Additionally, we've asked the department to comment on any impacts from abolishing these positions on facility operations and funding. Next, we've also noted there's an increase of 19.82 contractual FTEs in fiscal 2027. This includes 12 contractual FTE positions at Perkins and 11.56 contractual FTE positions in the Office of the Secretary. We've asked MDH to comment on the reason for the increase in contractual FTEs in each of these programs. Finally, on personnel, I also wanted to point out that in fiscal 2026, there was a realignment of 31 vacant positions from the Thomas B. Finan Center to the JLG Rika Center, one of the youth psychiatric facilities. In the budget bill of fiscal 2026, there was $3 million fenced in the Behavioral Health Administration to address pediatric hospital overstays, which was meant to be spent on staffing at JLG Rika. We have asked MDH to clarify if these realigned pins from Finan will be supported with that $3 million that was included in the fiscal 2026 budget or supported with existing resources in the Rika budget. The issue that I'm going to discuss has to do with state hospital facilities. So this section talks about some of the challenges that I've already noted earlier with regard to the state hospital facilities. Again, all of the adult psychiatric facilities are operating at capacity. They all are operating a wait list as well. We've also noted some vacancy and staffing issues. So the exhibit on page 18 shows the number of filled positions and the number of vacant positions at each state hospital facility, as well as the vacancy rate. And we notice the highest vacancy rate is in JLG Rika. So again, there was $3 million in the fiscal 26 budget for staffing at that Rika facility, and 31 pins were transferred from Finan. We have asked MDH to comment on how it will fill those positions and clarify why it transferred vacant positions from Finan, given that this Rika facility already maintains a high vacancy rate. This section also talks about some capital projects that the department has undertaken to try and expand bed space and improve the facilities, including a renovation of the North Wing at Perkins, which would expand the capacity for maximum security beds. This would, in effect, reduce the number of lower security beds at the facility, and so we've asked MDH to comment on how other facilities will accommodate this reduction in medium or minimal security units. There's another capital project that's ongoing to expand bed space at the Rika facility in Baltimore by 48 beds for a Facility for Children program, which is a program that supports children and youth that are court-ordered to seek treatment. There already is an FFC on the JLG Rika campus, so this would expand that capacity in Baltimore. There is also a potential project with the Department of Juvenile Services, which is located, which has a center, the Noise Center, located next to the JLG Rika facility. And so there's potential that they would operate an FFC at the Noise Center. We've asked MDH to clarify if operational funding for an FFC at Noise would be budgeted in the Department of Health or in DJS budget, and how much it would cost to operate that facility. The next part of this discussion summarizes the May 2025, or excuse me, the March 2025 fiscal compliance audit for the RICA facilities. And Appendix 2 summarizes some of those findings. And then finally, I'll just note this last portion summarizes some of the actions that the Department of Health has taken to address a few of these issues, including the emergency HVAC project at Perkins that took place last year and is ongoing, set to finish in August. The facility lost heating in November of 2023. So that delayed the renovation of the North Wing project. And then they're also focused on filling vacancies, especially at Perkins. We've asked MDH again to explain why the positions at Perkins were abolished and whether the number of authorized positions in fiscal 27 aligns with the department's goals to maintain adequate staffing levels at the hospital facilities. Finally, DLS recommends adopting committee narrative to request a report on staffing at state hospital facilities. That concludes my presentation. I can take any questions.
Thank you so much for your analysis. We really appreciate it. Do any subcommittee members have questions for our analyst? Seeing none, thank you. I'm going to welcome the MDH team here to testify on behalf of the MDH administration budget, please. Thank you.
Good afternoon again, committee. Again, my name is Kate Wolf. I'm the Chief of Staff for the Maryland Department of Health here today on behalf of Secretary Seshamani. And I have colleagues here who will help with answering questions. Thank you so much, Chair Shetty and members of the committee, and to our DLS colleagues for their support and engagement on this budget. I also want to start by just apologizing. It came to my attention that we had a delay in getting our testimony to you for this today, so I will do my best to walk through in detail, and if there are things that we need to follow up on afterwards because you haven't had enough time to look through the material, again, happy to do that, and apologies. So we are here to talk about our administration operating budget, and the first question was to talk about our high levels of overtime that we have at our facilities for FY25 and 26, and talk about what we're doing to try to reduce the use of overtime. We've really seen overtime costs continuing to increase for a few specific reasons. First of all, we've had successive years of COLA and step increments that have increased the cost of overtime sort of regardless of the number of hours used. Second of all, as you all know, in our Maryland healthcare system, it's very unique. We have facilities with 24/7 staffing requirements, specialized staffing across our operational and clinical positions. And when we look together at our vacancy rates and then paid leave, including leave authorized through the Family and Medical Leave Act, this compounds to increase our reliance on overtime to staff shifts across our facilities. A third driving factor is the high acuity of the patients that we're seeing in the healthcare system these days. We have patients that require 1-to-1, 2-on-1, sometimes up to 4-on-1 staffing ratios, which really increases staffing demands from our limited pool of staff that we have at our facilities. For patients that require off-site medical treatment or doctor's appointments or in alternative locations, sometimes up to 4 staff are required to go with those patients. Those staff would then stay with that patient through the duration of their appointment, again, putting a higher burden on the facility staffing needs when those staff are off-site doing those visits. And our current staffing models do not accurately reflect the sustained increased need for our high acuity patients that we have driving these enhanced staffing levels. We are really working on this issue to try to address overtime costs by continuing to work to fill our vacant merit positions, especially those in our security and nursing classifications that really are where we're seeing the overtime utilization the most. and also continuing to work with HR to look at our policies and procedures in this area, and happy to continue the conversation about that. Switching gears a little bit, the next question is about the opioid restitution fund and the FY27 allowance for our state allocation purposes. And so I'm providing this response on behalf of our colleagues at the Maryland Office of Overdose Response. The 2027 allowance of $28 million includes $14 million for the targeted abatement grant funds to be distributed to subdivisions upon receipt and approval of a local abatement plan. We have $10 million identified for state discretionary abatement funds to be awarded via the grant process and to support current 2-year grant programs. $50,000 to support buprenorphine optional protocol training grant program. About $350,000 to support more staff that are responsible for overseeing the opioid restitution fund grants and the program director. $4 million is budgeted to expected settlement payments from the state allocation to support funding for projects identified for funding by the state. So right now, the projections for those expenditures are around the implementation of SB 1099, around AED and naloxone co-location initiative for about $200,000. There's about $4.3 million in other planned projects and grants, $72,000 for the opioid settlement dashboard, and $87,000 for a fiscal map contract. To support the balance of the ORF state allocation expenditures, Moore will be submitting a budget amendment and does believe that the revenue is sufficient to support these planned expenditures. Moore is also completing an internal review of resources available to the state for addressing substance use and overdose, which will provide critical insight. We will utilize that information in addition to the ORF Advisory Council recommendations, other subject matter experts and community members, to develop a long-term plan for the opioid restitution fund spending. When reviewing the potential to distribute these funds, it will be critical to consider with intentionality allocating funds effectively to create the greatest impact to help those most impacted by the opioid crisis. This is particularly important now given the current ambiguous landscape of funding for substance use programming, particularly with some of the federal implications that we've been talking about. And it's even more imperative now that a sustainable plan for utilization of ORF dollars that prioritizes the highest impact programs is in place before significant expenditures begin. So more to come on this as we're working through the process. Shifting gears back to our healthcare system facilities, we were asked to talk about our position abolitions, given, especially at Perkins, given the facility's challenges with vacancies, and to talk about the amount of savings resulting from abolishing those positions. So you've identified that we have 15 merit positions at Perkins that are abolished in the FY27 allowance to offset the cost of reclassifying 26 other positions at Perkins. So the abolishments and reclassifications did not result in any reduction to the facility's budget, so we're not seeing a cost savings there. All of the 15 positions that were abolished were authorized for creation back in FY25, but have never been filled, so the closures of those positions don't have any operational impact. The 26 reclassified positions better align with our current operational needs around strengthening the nursing bench, around expanding administrative support positions to bolster operational functions, increasing staffing for the work adjustment training program to help accelerate treatment progression and discharge planning, adding an alcohol and drug abuse professional counselor to expand substance use services, and adding a psychologist capacity to increase the timely psychological testing to support patient management and treatment planning. We were also asked to comment on the reason for our contractual FTE increase in each of our programs. So there are 12 additional FTEs increasing in contractual positions at Perkins, and that is for patient work opportunities. The FY27 budget establishes a budget for a longstanding initiative that we have called the Work Adjustment Program, which provides structured therapeutic work placements that promote skill development, accountability, and readiness for community reintegration among our patients at Perkins. Patients who are part of that program participate in supervised roles essential to hospital operations, such as dietary services, in laundry, in library services, and the program is currently serving 26 patients. We have an additional 15 that are on the waiting list, and so that reflects a demand that we have, but limited staffing capacity to support that. We also have 11.56 contractual FTE increasing in the Office of the Secretary, and that's for newly budgeted positions in FY27 within our Office of Enterprise Technology, or OET. These are job functions relating to our cybersecurity response activities. So the budget for these positions is not new, but it was realigned from other budget objects, and we have in our written testimony a chart that highlights specifically where that was all realigned for, so I'm happy to answer any other detailed questions about that. We were asked to clarify about our realignment of PINs from FINAN to the JLG RICA, if that would be supported with the $3 million supplement in the FY26 budget. And yes, that is correct. So the payroll for the 31 realigned PINs for staffing the pediatric overstays unit will be supported by the $3 million line item in the FY26 budget. We were also asked to comment on how other facilities will accommodate the reduction in medium or minimum security units at Perkins as we're undergoing the renovation. And so we are working through that plan by having planned renovations at the Springfield Hospital Center, which will add 1 new admissions unit and 1 new subacute unit to our MDH hospital system. So that will be a total of 47 additional beds. And then for the patients at Perkins now, we are expecting that 10 of the minimum security patients will be discharged within the next year. And then we have the new subacute unit at Springfield, which would take 22 of the Perkins minimum security patients, and then any remaining patients would be transferred to one of the other hospitals in the system, but primarily through the use of the Springfield beds and discharges. We were asked to comment on how we will fill our positions at the JLG RICA and why we transferred vacant PINs to JLG RICA while we have a high vacancy rate there within our existing positions. So this is a good question. So the JLG RICA's current vacancy rate as of January 31st was 20.7%. And that is a result of 68 new merit PINs that were authorized in FY25 to staff new units in Cottage 2, as well as the realignment of the 31 merit PINs to staff the pediatric overstays unit in Cottage 2. So this initial addition of the 68 merit positions increased the facility's vacancy rate from 5.1% in October 2024 up to 21.2% in November of 2024. That vacancy rate has fallen steadily since then. So in November of 2025, the vacancy rate was down to 11.8% as we were filling those new PINs and opening 2 of the new units. The vacancy rate again increased in December when we added the 31 new positions. So now it's back up to the 21, or now it's at 20.7, but it was up to 21.1% in December. So again, we expect that the vacancy rate will fall again as we are hiring into those positions, as those PINs continue to be filled. We expect that the vacancy rate will be back down under 10%. So we are working really closely with our Office of Human Resources to make sure that all of the positions are reclassed appropriately for the pediatric overstays unit. Recruitments are open. We are trying to expedite hiring in every way we can, and we do expect filling those vacancies starting next month. So, we were also asked to clarify some questions around operational funding for FFC at Noyes, which is also on that Rockville campus if that's budgeted in MDH or DJS, and then how much it costs to operate an additional FFC. So yes, the facility for children, the FFC, will be budgeted within MDH, and our estimate annual cost for that type of programming is about $5.7 million a year. Back to Perkins, we touched on this a little bit, but a follow-up question on positions that were eliminated, and then whether the number of positions that we have authorized in FY27 aligns with our goals around adequate staffing levels. So again, the 15 abolished positions were vacant and were never filled, so it didn't impact existing staffing levels. And then the realignment of those budget resources for those 15 positions are used to fill 26 existing vacant positions in those other classifications that are most needed by Perkins. And as far as our staffing levels go, we are actively exploring some procurement options for a third-party analysis of facility staffing levels, not just at Perkins, but across our entire system. And we also, our understanding is that our partners at AFSCME are planning to conduct a staffing analysis as well. So we can work together with all of this information that we're trying to gather to inform future budget discussions around our adequate staffing levels, just to make sure that we are all coming with the same information. Our colleagues at DLS have recommended adopting some narrative requiring a report on staffing at the state facilities, and we concur with that recommendation and look forward to continuing to share information out of these projects. And then I think the last topic is related to our IT projects, and is a question related to our electronic health records project and the estimated remaining costs being listed at a level more than twice the amount needed for the project, and comment on if our anticipated project costs exceed the estimated maximum total cost. So according to our records, our electronic health records major information technology project has spent about $15 million of the total appropriations that are allotted to the project. That project estimate at the completion of the project is expected to be about $32 million. So the remaining estimated cost is about $17 million. At this time, we are not estimating a total cost to exceed $40 million as listed in our budget highlights appendix. And I think that covers the questions we were asked to address, and I'm happy to open it up and have my colleagues here to help answer any additional questions.
Great, thank you so much. Delegate McCaskill.
Thank you, Madam Chair. Please bear with me, be a little patient with me. I want to go two places. First, being the representative for District 44, UMBC. I get a lot of questions asked around UMBC, Spring Grove, relationships, et cetera. So I'm wondering, what do you find to be the vision for Spring Grove? Does the department foresee moving to an entirely new site elsewhere in the region, or perhaps ultimately leasing land from UMBC for a new hospital site somewhere on the existing site at some point?
Thank you for that question. So as of now, we engage in an agreement with the university to, they basically own that property, and we are able to stay there for another, I believe, 17 years.
Right.
So we do have some time. We are working collaboratively with our Department of General Services partner. This is one of the priorities for us as we move forward to determine, what is the path forward. And I think it likely will be a different facility, but we are still in the planning phases at this time for that.
Thank you for that response. It would be nice to have follow-up occasionally as you all plan the vision for that, because I get asked that quite often of what's going to happen with that. And even though it was $1,
Yes.
the investment is quite costly.
Absolutely.
I want to move to another more serious, a few more serious questions for me, and it's about these personnel changes. And it's serious for me because I hear that the assaults remain high. I see, you know, reading this report, and even talking to my friends that asked me, there are major concerns around, because I heard you say that there was zero impact operationally. Yet we keep hearing of this overtime. We keep hearing about the assaults. And I'm trying to work my brain through understanding how we can have high vacancies without a real impact on the clients and the workers. And so I want to go for the record a couple of questions, Madam Chair. Again, on page 14 of the DLS report, we want to go back to these abolishing of the 15 positions in Perkins. And trying to understand why they were permanently eliminated, why any vacancies are eliminated, yet we still have high overtime. We got to consider things like leave, et cetera, right? Burnout, and the safety of our workers. So I'm trying to understand why, or what these challenges are of filling them. Why are we staying stagnant with this? And so, despite eliminating them, what challenges you're finding here with vacancies?
Mm-hmm. Maybe I'll start and then ask Melissa, who's our HR director, to talk more about the work that we're doing with Perkins in particular in our facilities. So I want to say, so the positions that were abolished were not filled. And so that's why we note that they didn't have an impact on operational staffing levels. Like, we didn't, you know, fire 15 people and abolish those positions. So I just wanted to make that clear. This is an area that we've been working as a leadership team to address, and with the new leadership at Perkins with Dr. Jones has been really trying to fill the vacancies across all of our positions. Again, to your point, to make sure that we have adequate staffing for our security and the safety of our staff and our patients. So Melissa, do you want to talk a little bit about the work we're doing?
Sure. Sorry.
No,
It's okay. Am I good?
Yeah.
Can you hear me? Hi, I'm Melissa Easley. I'm the Director of Human Resources for the Maryland Department of Health. I can speak on some of the initiatives we have taken over the last year. I joined in this role November of 2024. And since then, we have seen significant reduction in the vacancy rate across our facilities. We do have a committee and outreach team in our recruitment division that has been working directly with Perkins and Spring Grove and some of the hard-to-fill positions, where we've had on-site job fairs, doing on-the-spot interviews to help fill these vacancies, which contributed to some of the decline in the vacancy rates. We also now partner and join the governing bodies with the CEOs to discuss some of their challenges in filling the positions. So where these 15 positions were eliminated and the 26 came from the new leadership within Perkins, to really take a look at like where we are now and to try and realign the positions to better meet the needs of the patient care, and of course to then help the employees that we have on site there by filling some positions that didn't exist at that time.
Okay, I'm still trying to wrap my mind around how you're even able to manage these facilities with such high vacant rates. For instance, Perkins, I have 115 vacancies. Am I correct with that?
Let's see, I can see the exact number. I know that vacancy rate is about 18% right now. But they are reclassing those other 26 to try and fill those new positions. Some of those did come from security pins that were created. I would defer to
the healthcare system and budget for the specifics on that, but there were, I want to say, about 60 PINs, if I'm not mistaken, that were created there in 2025 fiscal year, I believe. So that also impacted the vacancy rate, and I do know that when Dr. Jones joined, they were looking at it, and of course they want to create a more therapeutic setting as opposed to, you know, the security feel. Of course, you need to have that balance, but that was the driving factor of having these 26 PINs that were part of that 60 who were all security, to find other therapeutic classifications for the facility and the patients.
I'm sorry, sorry, 1 second. I'm so sorry to interrupt you here, but can I just jump in for just 1 second, Madam Delegate? Is that okay with you?
Absolutely, I yield to you.
You're so kind. I recall this discussion when we created these PINs, and the purpose of the creation of them was to address the staff assault situation that was happening. And I'm curious why, after these decisions had been made to provide added security, well, yes, we absolutely want to make sure that the therapeutic component is maintained, why we're now talking about reclassifying them into other options when we're still seeing a problem with staff assaults. Can we talk about that?
Yes, and we can provide some additional feedback specifically around these 26 PINs that we are trying to hire that we do believe will contribute to increased support for patients to help continue to reduce the need for, as Melissa was saying, the more correctional focused type of security focused on the patients that we have in our facilities now, to talk more about how we see and how Dr. Jones at Perkins is really envisioning these new PINs as being a really essential role in the security framework for our facilities. So that really is part of what we're trying to do with the new leadership at Perkins, and really reevaluating what those staffing needs are. I think, as we've mentioned, getting a third party to come and look at our facilities as well to help us assess, you know, is it that we need more in the traditional security attendant type roles? What we have been looking at over the past couple of years is for the nursing support, the therapeutic support to make sure that our patients are getting the services that they need, so we don't need as much in the security type roles. But I think we really want to work in partnership with our stakeholders to figure out what the right mix is, because the patient population has been changing so much as well. So that's something that I think when all of these, as the facilities were stood up and as we were allocating PINs and staffing resources to them, that the patient mix has changed now, and we need to do better and change our staffing to better align with the current patient population.
But I'm sorry, the patient mix has changed since like a year ago when we added these?
No, I think this has been a long-term process.
Okay, I'm sorry, I'll yield back to my good friend from Baltimore County. I apologize. Thank you.
Sure. So I I heard that there has been zero cost savings and zero operational impacts. There's been, and that sounds nice. But I'm looking at the DLS on page 15, there are like over 500 vacancies, right, as of December 2025. With approximately, this is the part I had to underline, with approximately 90% of these vacancies being at state hospitals. And so you mentioned a third party, but you also mentioned the stakeholders. And I'm glad you mentioned that, and I'm hoping that the stakeholders are the workers, because I'm still back to my first thought of managing. How are we managing the facilities? Obviously, we have to force these workers into overtime because of a high vacancy rate. And so I am looking forward to you bringing everyone to the table to work on these vacancies because we can't keep speaking on cost savings when we also, in the same breath, have to have the conversation about overtime. It's just that something's not equaling there to me. But then what's more important to me is two things: assault and work environment for our workers. And as you may already can tell, I am a union member of SEIU. But the other part of the equation for me is how are these workers being able to give adequate services to those we are serving? Something's not sitting right with me. And so I'm looking forward to follow up. I don't necessarily need, all the numbers and data to look great on paper. I need to actually know that there is some movement happening in the facility, because I keep feeling like we're having these conversations over and over again. Thank you.
Yeah.
Thank you, Madam Chair.
Thank you.
Thank you. Delegate Heimbaugh.
Thank you, Madam Chair. I just want to follow up on the vacancy thing real quick. Have you looked at what are the impediments to filling those vacancies? Is it working conditions? Is it overtime? Is it background checks? Is it physical, potential for physical harm? Have you looked at those? And if you have, what kind of initiatives have you considered to make it more attractive to fill those positions, whether that's bonuses or other kinds of benefits or whatever? I mean, obviously, it's tough to fill those jobs, and you're going to have to do something extraordinary, I think, if you ever want to get further along than where you are in terms of filling the vacancies.
Right. No, they are definitely tough jobs to fill, and, just like I said, in the last year, I've built a, pretty, I would say, great rapport with, like, AFSCME. I have one-on-ones. We're having our LMC coming up on the 24th. We touch base monthly just to talk about concerns and when things pop up. I think there's a lot of contributing factors. I mean, it also depends on the region that we're talking, Western Maryland or on the shore. But we have done, like I said, the on-site job fairs have definitely been successful, which helped dramatically reduce, like, our Perkins and Spring Grove numbers over the last, year and a half. Because we bring the candidates to the facility. We have on-site interviews. We've been giving walkthroughs and showing them what the dynamic is, which also helps, I think, with our retention as well. Because before, you could come to headquarters down on Preston Street or apply online and not see the facility or meet with current employees. So I will say that we have seen great success there with having the job fairs actually on site at the facilities. I know we've done 3 at Perkins, I believe 2 at Spring Grove, and we've also expanded that, and we have our outreach team now as part of our recruitment. So that's something that we stood up where we post more on social media. We have an outreach team for some of our hard to fill areas and units. So it's a continuing process that we're just trying to gather the data, working with the CEOs and, of course, the employees. AFSCME and myself put out a joint staffing letter to the facilities to let them know that AFSCME would be on the ground and that we are in partnership with this. So I think just trying to really have that collaborative strategic plans to really identify the areas, and we've been doing targeted focuses like we did for Perkins or Spring Grove when their vacancy rates are high, where we can jump in and help support their on-site HR from a headquarters standpoint.
So, if I could just for a minute, I assume you have a relatively high turnover rate too. I didn't see any numbers on turnover, but so when people leave, are they interviewed to determine why they're leaving the job, what caused them to leave?
Yeah, so that's something that we just recently put into effect, whereas before at each local location, they had their own exit interview and process. And, our thought was, sometimes when you're giving the information and feedback directly to the, maybe the leadership that caused you leaving or the hospital or local level that maybe was part of the contributing factor to leave. So now we have a statewide, like it all comes to headquarters, so we can start tracking and analyzing the turnover rates and look at some of those areas. So the feedback comes to us, and then of course we're gonna, share it with our CEOs and health officers or program directors where there are concerns. But I think that'll be helpful where people can, have that direct line to headquarters and to leadership, as opposed to just giving the information at the on-site location. That's something that has also been helpful. And we have someone from one of the facilities came up to talk to us yesterday. So really just trying to, let them know that they have that lifeline to us as well, that they can reach out directly to headquarters. So the exit interview was one of our initiatives with our new HR leadership at MDH that we just got up and running.
Okay, thank you. A different subject. The 31 positions that were transferred from the Finance Center in Allegheny County, which I represent part of Allegheny County, was the assumption that because they were vacant, they could be transferred without having an adverse impact on the Finance Center? Was that the thinking?
Those positions were allocated in advance of an expected renovation to happen at Finance Center, which has now been delayed and probably won't happen for another year or two. So they were budgeted for opening a unit that isn't ready to go yet.
And when is the renovation of the Finance
It's
Centers?
part of a capital plan, so it hopefully will happen within the next 2 years, but not in the short run.
Okay, thank you. Thank you, Madam Chair.
Of course. Thank you, Delegate. Okay, I'm going to ask a couple of questions, if I may. Thank you, team, for being here. So I want to start with maybe an easier one. Can you, I think, Ms. Wolf, you mentioned a total project cost of about $40 million for an IT project. Can you remind me what that's for? Is it updates to an existing thing? Is it for the entire administration? Is it for, talk to me about what it's for, please.
Absolutely. We are implementing an electronic health record system, which doesn't exist at this time for all of the 11 24/7 facilities managed by the department. So this has been a project in progress for a while now. So it's from foundational gathering requirements, working with the vendor who is NetSmart, to configuring, testing, rolling out. It also involves integrations with like pharmacy software and lab software to sort of like streamline the processing that the facilities are doing. So listening into some of the questions, this may be a contributing factor to sort of with the improved technology, maybe reducing some of the staff burdens that we were talking about earlier.
Okay, great. And will that new program facilitate some of the discharge patients are?
Yes.
Okay,
Yes.
great. That's helpful. Can you give me, please, a timeline for the status of the reopening of the noise facility in Montgomery County? I know you all are working with DJS on that to soften the facility and allow for it to be reutilized, repurposed for therapeutic treatment for adolescents.
Yes, we're hoping that that will be ready within, hopefully by June, for the kids to move over from the Reich into the noise facility.
Okay, that's very exciting. Thank you. And will there be capacity for children outside of RICA to be treated there too? Because I know part of the purpose of opening that facility or reopening it in this new form was to provide for capacity for young people who are facing like treatment needs.
Substance use treatment needs in particular, exactly. So we kind of did a trade. So we're going to move the facilities for children, which is the services that we provide, attainment services that we provide for court-ordered children. They will move to noise, which is better suited for them physically, and also we need to expand the FFC, and we'll have more room there. And in turn, we are going to create a unit in RICA with that DJ's funding for the SUD treatment. So we switched facilities, but we're providing the same amount, if not more, capacity now.
Okay, and how will that facility that you're building at RICA be different than the facility beds that you're creating for pediatric hospital overstay?
So we have one cottage at at Rockville Rica that has 3 units in it, and 2 of those units will be overstay, and 1 will be for SUD. So we already have 1 unit, and that was theoretically for overstay, 1 unit for the FFC, and there was 1 that wasn't staffed. The one that was theoretically for overstay also had FFC kids. These are court-ordered children, and we have had a wait list there and been potentially held in contempt. So the FFC kids have been taking up 2 units in Cottage 2. We're moving them to Noyes, which will open up 2 units for overstay children, and then we are staffing the 3rd for the SUD. So 3 units total in Cottage 2, which will do 2 overstay units and 1 SUD unit.
That's great. How many beds does that mean?
15 beds total.
15 beds total across the 3 units? Per
So
unit.
15 beds in Cottage 2, and then another 8 beds in Noyes.
Okay, great. That's great. Want to ask a question about, so much of the work that you all do is really in coordination with the BHA budget. It's really a shame that we don't have you all together, truthfully. So I'm convinced that we will probably have some follow-on questions in that budget that are related to the work that you all are doing also. So just flagging that. So I want to talk a little bit about court-ordered patients and the work that you're doing there. A lot of really important information in the DLS analysis there, a lot of challenges in finding adequate placement. Can you talk a little bit about, and this I know is going to be more in depth in BHA, but how will the rollout of the assisted outpatient treatment plans across the jurisdictions this year and in future years potentially impact the out-of-court placement challenges that you're facing in this budget? Sorry, I know that's a complicated one because it spans multiple things that you all are working on, but given the purpose of AOT was really to address this concern, I'm just curious if you all have any crystal ball answers.
I don't know that it's a crystal ball answer. I think AOT is going to be a tool in the arsenal, the continuum that we're looking here. Arsenal is probably the wrong word. But the goal here is to make sure that people are in least restrictive settings, that they are in the community and being supported, and being so that we can avoid the hospitalization. So it will have an impact on those numbers inevitably, but I don't know that I can quantify that or have the numbers to quantify that. It's
Okay.
part of the continuum that we're looking at.
Okay, great. So we'll make sure we have a longer discussion on AOT and the plan from the administration in the BHA budget, please, at that point. I want to, let's see, so we talked a little bit about pediatric hospital overstays and the questions I had related to that. I think you all answered a lot of questions around the realignment of staff, so thank you for clarifying that. I think that concludes my questions for this hearing. Does anyone else have anything else? Thank you for your work. We have many more budget hearings with you to come. Really appreciate you joining us today. As is the tradition of this committee, please stick around for our advocates that have signed up to testify. And we actually have 3. I misread. I apologize. So you all are dismissed, and we'll now call our advocates to the table. Of course, so we have 3 individuals signed up favorable with amendment. We have Alexis Hunter with AFSCME Local 539, Jenny Reese, AFSCME 539, and Denise Gilmore, AFSCME Maryland. Welcome, and the 3 of you may begin when you are seated and ready. Thank you. And before I forget, just a gentle reminder to our friends here that witnesses are provided 2 minutes each for testimony. And as I like to say every day, everybody needs a Joe. He will be timing today. When you hear the alarm, please go ahead and wrap up your comments, okay? Thank you.
Thank you. Good morning, good afternoon. My name is Jenny Reese, and I serve as the MDH Unit Vice President for AFSCME Council 3. Our union represents more than 5,000 employees at the Maryland Department of Health, including staff in all 11 MDH facilities across the state. Our members serve Marylanders' most vulnerable residents every day as housekeepers, electricians, cooks, office secretaries, nursing assistants, psychologists, supervisors, and many more essential roles. We are deeply committed to providing the treatment, care, and dignity that every patient deserves. As of January 14th of this year, we had over 386 vacancies in frontline bargaining unit positions within MDH facilities. This level of understaffing drives high overtime costs. Our members have no choice but to work extra shifts. We must ensure continuity of care and the patient's safety is maintained at all times. Investing in the state workforce that cares for our most vulnerable is not an option. It is a necessity to maintain 24/7 operations. I can personally attest to the impact of this work. As a licensed practical nurse working admissions at Springfield Hospital Center, I have met patients on some of the worst days of their lives. To watch someone move from crisis to stability, becoming safe, healthy, and ready to return to the community is extraordinary. It's why I became a nurse and why I'm a proud Maryland State employee. We are asking for the resources necessary to allow us to continue this life-changing work. That includes competitive wages that keep up with inflation and annual step increases that reflect the skill, responsibility, and dedication our workforce brings every day. Competitive wages are essential to recruit and retain staff, especially in these times with incentives in the private sector continuing to increase to address the shortage in the healthcare workforce.
Ms.
Thank
Reese,
you.
we are so grateful for your testimony and thank you for your service to our state. Thank you. Yes.
Hello, everyone. My name is Alexis Hunter. I'm one of the members of ASME Local 539. I am a licensed clinical social worker, and I'm testifying on the need for more funding towards our MDH facilities. As the analysis highlights, Maryland law requires the health department to admit a defendant deemed incompetent to stand trial and dangerous within 10 days of a judge's order. However, it can take months to have a patient admitted at any of our state-run hospitals. There are many factors that contribute to the long waiting list, but I would like to address the understaffing of state facilities. For example, as a social worker, one of my job duties is to run a competency group. Competency groups help patients become competent to stand trial. These groups also cover topics such as the roles in courtroom, plea options, role-playing trials in the courtroom, and assisting patients to understand their charges. However, we often do not have enough staff to run these groups. This isn't unique to my hospital. In one particular hospital, there is only one competency group per week for each unit in the admission building, one competency group per week for each entire long-term care building. Each long-term care building has 3 units that house approximately 25 patients each. One group a week is not enough to help a patient become competent in a timely manner, especially considering the number of patients at a state facility. This is happening because we do not have enough staff to help run these groups, whether it be in a rehabilitation department or nursing department. I'm in this job because I do enjoy helping these patients who come in at the height of their psychosis and help them get better so that they can be stable and return to the community. Previously, I had worked with a patient who came in very suicidal, was always on one-to-one, and was significantly aggressive and difficult to manage. But I had a special connection with him and was able to help him to get to restoration, and he is now in the community and living safely. I love my job, and I hope to continue in this role, but we need to have more resources to adequately serve our patients. Thank you.
Thank you so much. Ms. Gilmore.
Hi, Denise Gilmore here with AFSCME Maryland. Our 11 MDH facilities on average were established 75 years ago. The oldest being Spring Grove in Catonsville, so we appreciate the question previously, Delegate, which was established in 1797. And it currently treats over 400 patients and employs around 800 staff. We do think it's time for a real building plan for these facilities so that our state hospital system can continue doing the great work that you heard our members talk about earlier. But we do think this assessment should come with a real operational assessment as well. And I have to say, we heard discussion earlier that that the department plans on, procuring a kind of outside vendor to do this. We actually think this is an area that we could achieve some cost savings. In FY25, the state spent $177 million on management consulting services. We actually don't think, for 3 years, we've been asking to work in conjunction on a staffing plan. How about if we don't spend money on an outside consulting plan and just work with the union on this? The study on forensic hospitals, they've been around for decades. We have a consultant report after patients were murdered at Perkins from 2012 that I'm happy to share with the department. We have another one out of Spring Grove that I'm happy to resurface if we need it. This issue has been studied. We think we can probably move much faster on this. We know there are efficiencies that can happen when we ask our frontline staff. The system is currently licensed for 400 more beds than it's staffed and budgeted for, just something to think about with all these long waiting lines that we constantly hear about. And I'll just close, in tight budget times, the temptation is always privatization. We don't think that's an efficient or easy way to save costs. We had a horrible situation, unfortunately, at Eastern Shore Hospital Center over this recent snowstorm, where there's a privatized dietary department where patients didn't get meal trays. Those are services that we can bring in-house. DGS has done some really good work in consolidating contracts. That has helped us really figure out where there are efficiencies in our procurements. Dietary is a place where we bring that in. We think we can save money. The rest of the system has in-house security. Same thing with maintenance. We're spending a lot of money contracting out facility services. If we brought those in and had in-house services to do maintenance, we know we can save some money there too. So with that, we appreciate your continued advocacy for our state hospitals. They do incredible work. So thank you for your support.
Thank you so much for your testimony, Delegate McCaskill.
Thanks again. So I just want to, make a comment and just say thank you. I just want to personally lift you all up, because I know that you do such a tough job, but yet every day you return and you give it your absolute best. And then you're faced with overtime and you have to give even more of what you probably don't have. So that's my comment. I'm grateful for you. I had a family member who actually was a patient at Spring Grove back in the 80s. And I loved the facility. For one, it gave my family member exactly what he needed. The campus was beautiful. It was inviting to family. Administration allowed us to come in and sit down and also have a take on with the doctors of what we thought would be the best care for our family member. And he was eventually able to also return to our community where he was safe, and so was the community. And so I am grateful that back in the day, the facility could give everything to both the client, the families, and the staff and administration. And I'm looking forward for that to be once upon a time again. I did want to mention about the third party, because I am concerned about cost savings. I am concerned, I am a child care provider. I preach it all the time. And one of the things that our agency, we are regulated under MSDE, is once upon a time we had a third party to come in to say exactly what we had been saying as providers for 5 years. And it was a cost, an overwhelming cost to the agency. And it was actually quite wasteful, because we could have gotten this done in a more expeditious time. And so I am really hoping that the agency hear you and the administration hear you, that is something that you can come to the table with and reconsider. When you're doing that, I see the nodding of the head, so it's making my heart so warm to see that. But to you all, whoever wants to answer it, do you agree that there is inclusion with you all as we make a lot of these considerations about workforce?
Jenny, you want to take that?
In comparison to the previous administration with the department, we have made, we've definitely bridged that gap. However, we are still looking to collaborate more and have more of a say when it comes to policy, procedure, operations, because we are the front lines, we're doing the work, and we also know what needs to be reflected in there. So also when Joint Commission comes around and we, sometimes we get dinged on something that isn't necessarily necessary. So, we do want to have more of a collaborative relationship with the administration. Unfortunately, we had a month and a half of October and the first 2 weeks in November for 2-day site visits for the 11 facilities to start our staffing analysis. Unfortunately, it took longer to get the notice sent out to these facilities that it was already into the holiday season. So that now has been pushed back to the spring we will start, and we are looking to meet for our Labor Management Committee meeting on the 24th of this Tuesday.
Perfect. Well, I do wish you all the best in your collaboration, and then as you all move forward, and that you eventually get exactly what you need so that you can continue to serve our communities as well as you do. Thank you, Madam Chair.
Of course, thank you, Delegate. Further questions for this panel? Thank you so much for your state service, and thank you for your advocacy. That concludes today's budget hearing on the MDH administration budget and concludes our budget hearing for today. See you all next week. Thank you.